Dr. Miron, thanks so much for joining us today.
Thank you. Thank you for having me.
We asked you to come on and talk to us because you recently published a study titled Cytotoxicity and Gene Expression Changes of a Novel Homeopathic Antiseptic Oral Rinse in Comparison to Chlorhexidine in Gingival Fibroblasts. This was published in the journal Materials, and I wanted to kind of just ask what led you to be interested in this subject area and this research?
Yeah. It's actually a nice paper that we've recently worked on, but it's got a huge background, and I would like to share it with you because I think it's quite interesting. So, a little bit about myself is that I'm a trained dual dentist as well as PhD in molecular and cell biology. Okay, so imagine, I do the clinical stuff, I've done all my dental school, but I was very different than the average dentist because I said, well, I'm going to go study at the molecular and cellular level what's going on with all of these cells and how they're behaving with regenerative materials or other things. And so I did a lot of research in that space, and I ended up winning. I'm from Canada. I won a big scholarship, and it allowed full funding for a PhD anywhere in the world. All travel expenses, living expenses, the whole thing was paid for. So I went to the top school in the world for research. So if you look at the ranking systems for citations per paper, and where the big hubs are, and the interest for me was implants. Most of the major dental implant companies are coming from Switzerland, right? So the Stromans, the Nobel Biocares, they're all Swiss. And so I went and lived in Bern, Switzerland, and I stayed there for 7 years. And throughout that time, I became head of preclinical research. And so all of these new types of biomaterials or new agents were always coming to the top school to do research because every company wants to be affiliated with our group in Bern, Switzerland, and get tested and validated within our team. So that's kind of the background there. Now, I was head of preclinical research of the dental school, and there was all of these different divisions. So we worked with 3 different departments. One of them was the Department of Perio, one was oral surgery, and then one was oral maxillofacial surgery, okay? And we were very international. Like I said, I was Canadian in Switzerland. We had Chinese people, Japanese people all over the world. And one of our oral maxillofacial surgeon, postdoctoral students that was coming from Japan, wanted to do research on antiseptic solution. This was back in 2015. And
Mhm.
believe it or not, a lot of people don't know this. Chlorhexidine has been a little bit, it's damaging to cells. Of course, it is killing all bacteria and it's effective at that, but it is also very hard on normal fibroblasts. And so 5 years ago, we did this research where we wanted to compare different types of antiseptic solutions on the behavior to fibroblasts in the bone cells. And amazingly, we found that of the 4 materials that we tested, all of them killed, a huge majority of these fibroblasts within a matter of 10 seconds. Okay, so if you take chlorhexidine and you put it as an oral rinse into somebody's, let's say, open third molar, it's going to destroy bone cells. Okay, and it's only a rinse of 10 seconds. So it was actually quite surprising to see that. And many clinicians that live in North America don't know, in fact, that chlorhexidine is banned in many countries. Okay, so it's not chlorhexidine, even though it's standard in North America and a lot of people are using it, it's actually banned in many countries. So this was work that I did 5 years ago, and we published 2 really nice articles on looking at how much time you should be rinsing with each one of these solutions to make sure you don't kill cells, and it was like a fine balance. I moved back to North America after living in Switzerland for 7 years in 2016.
Mhm.
And of course, I had a lot of background on research and biomaterials and growth factors. And I was invited to collaborate in Dr. Picos. So Michael Picos is an oral surgeon in
Mhm.
Trinity, Florida, who teaches some of the best courses available in North America for implants and GBR and sinus grafting. And he was using this new product that was called StellaLife. And apparently it was more homeopathic, so it was better for your health. And he was saying that it was working much better for him clinically than was chlorhexidine. So I was looking at this and I said, wow, this could be a solution for all of these problems that we had back in Switzerland, and it would be very interesting. And so over the years, I've kept a very close collaboration with Bern. So I go there 2-3 times per year. And I remember asking Dr. Picos if I could have a few of those StellaLife bottles, which was completely new to me. So it was this homeopathic antiseptic solution. And I brought it to Switzerland. And then I collaborated with the same people that I did the research with 5 years ago. I said, guys, this might be a solution to, these problems because they can't use things like chlorhexidine. And in fact, in the oral surgery department out there, chlorhexidine was banned. So then we ran the study, same study, everything was the same thing. And sure enough, this StellaLife was completely favorable to cells. So instead of actually killing them, and with chlorhexidine, you'll see in the study, very rapidly at low concentrations, even if you dilute chlorhexidine tenfold, so you have 10% of the chlorhexidine with 90% just normal saline, for example, it will still kill cells very rapidly. And with this new solution, it didn't affect cells that way there. In fact, it actually helped promote a little bit of their collagen synthesis and other release of growth factors, did not cause any inflammatory response, etc. So it was a first study to really validate that even at the cellular level, there was very good behavior with this new compound. So it was quite
Mhm.
interesting to study.
Yeah, and I first learned about StellaLife several years ago as an alternative to post-op, opioid pain medications. That clinicians were using this as a way to help often implant post-op patients deal with the
Yeah,
pain and recovery.
yeah.
And I guess if you were using chlorhexidine there to, keep the implant area from being infected, were you possibly retarding the actual healing that you were trying to
That
promote?
was the amazing thing. So actually, that you said that, I don't know if you've actually read some of the article itself,
I,
but amazingly, we actually found something similar to that. And so when we were doing these studies, when these cells were staying alive, one of the things that we were trying to figure out was we said, well, if the cells are dying with these antiseptic solutions, and of course, chlorhexidine is the most well-known one, then there must be something going on with respect to its inflammatory response. Okay. When we use StellaLife, we might have had a 50% increase in growth factors, such as platelet-derived growth factor, which is important for wound healing. Whereas with the chlorhexidine, we didn't really see much of an increase. In fact, it would actually go down a little bit. But that wasn't the big difference that we saw. The big difference is exactly like you said. When we looked at inflammatory markers, okay, and we were doing these cell studies with gingival fibroblast with just normal culture media supplemented with StellaLife, there'd be no change. So there's no inflammatory response whatsoever. When we put chlorhexidine on those same cells in the same environment, there's a 2,000-fold increase in inflammatory cytokines that are released. It's just like a big bomb of inflammation that goes off. And so exactly like you said, I actually believe today, post-op, if you rinse with chlorhexidine, you're going to induce inflammation. It's definitely going to kill bacteria, there's no question, but it's bad for gingival fibroblasts. And so it's a trade-off. You're killing the cells of the bacteria, but you're causing a massive increase in inflammation. And in fact, you're even killing some of the cells that are supposed to participate in regeneration, right? So that's the kind of, that's a real big trade-off, so to speak. And that's why I think if you give chlorhexidine to the opioids, to these patients that are in difficult painful environments, whether it be third molars or surgery, etc. The advantage here is that now you don't have something that's going to cause further inflammation, further pain, and then your patients take more meds and more opioids. And especially, like I said, with these third molars, who are getting these third molars extracted? It's usually 16, 17, 18-year-olds. And when they get chlorhexidine and it's painful, then they are complaining like crazy. And then they're saying, well, give me some opioids. And then they're taking it, and then they might get addicted. And surprisingly, when you read a little bit of that literature, most drug abuse starts from opioids that are prescribed by doctors and dentists. And it's just unbelievable because, like I said, if you can minimize that, and I love the message and the things that company stands behind. I think it's just a phenomenal thing that they're doing for society in general. But, I cared more, because I'm a cell biologist, what's going on at the cellular level? Does it really make sense? And when I saw the results and we published it, it was just, it was a real nice contribution it was the first study that ever looked at the effect of this homeopathic remedy on cells. And it's a real improvement.
Now, obviously these are, significant and kind of exciting outcomes. Was this what you were expecting when you went in? Did you think that there was going to be such a marked difference between what was kind of in the US standard with chlorhexidine versus what StellaLife's products do?
I don't really know we don't really expect anything in research. The more we do, the more I don't expect anything, because I've just had so many great things that happen that were it just happened. And I've had things that I expected to get a good result and been completely, entirely disappointed. Right. And so it's the thing with working in research. It's not as predictable, so to speak, as being a clinician where you can say, okay, I place implant in this much bone and I expect to have this. And there's a 95+ success rate in research. It's all over the place. So I just don't expect anything at all. I would say probably the most surprising finding that we had was the difference in inflammatory response to chlorhexidine versus StellaLife. So when you actually see, we typically in research will see small changes. I do research with platelet-rich fibrin where we have a 200% increase in gingival fibroblasts, or BMPs will improve bone formation 6 times, and we see in this range typically 1 to 10-fold increases. When you see something that's causing a 2,000-fold increase in inflammatory marker release from chlorhexidine, that's very significant, and that was surprising.
Mm-hmm. So, as with pretty much all research, you publish something, but it's not the end. You've got results from this study. What more studies is this pointing you towards? What else should we be looking at to kind of continue to refine protocols in dentistry?
So there's many studies that can be done on this topic. For one, it'd be interesting to see what the antibacterial properties are, and I know it's been tested, but more at the, if you go to a high-end research lab to figure out, okay, now we have a product that's not going to destroy good cells, healthy cells, and it's not going to increase inflammation, but is it really, what does it look like compared to antiseptic solutions that are commonly used in terms of reducing bacterial counts? And I think they're doing research on that right now. From clinics, like I said, you can literally do an array of papers on many different grafting procedures. For example, how is sinus grafting with chlorhexidine? How is sinus grafting with StellaLife? Compare them and do, for example, there's what's called a VAS scoring system, which is pain scores to patients. You say, okay, what's your pain score after the surgery? Right. And the problem is with chlorhexidine, imagine if it's causing inflammation, your pain scores are higher than if they take StellaLife, right? So there's big differences there. And it'd be interesting to see, those results for different procedures. Maybe for sinus grafting, it's more important because it's more painful, or GBR. What's it like in perio? There's all kinds of work that can be done thereafter. They have different ways to develop the homeopathic remedies. So whether it be in gel form or liquid form, what are the differences? Is one better than the other? For every one of these indications, there's many things that can be done.
Mm-hmm. Now, when it comes to homeopathics, there's just in general, for a while, the medical community seemed to look them off and kind of go, okay, these are, folk remedies or things like that. But are there challenges in studying something like StellaLife that incorporates a number of different ingredients into its formulation?
No, I don't really care, and I don't really buy into the whole holistic homeopathic thing. I do a lot of work with platelet-rich fibrin, which means, you take your blood, you spin it, and of course, all these holistic homeopathic doctors, they absolutely love me because, you're bringing a regenerative strategy that's holistic or homeopathic. To be honest, at the end of the day, I care about what works and what doesn't work. And whether it's platelet-rich fibrin, which is totally natural, or it's a bone allograft, I'm trying to find what's going to work best for every one of these indications. And sometimes it's a human cadaver bone. Other time it's a membrane that might be coming from an animal donor. Other time it could be blood that's spun, right, without chemical additives. Another time it could be StellaLife. When you have a patient that's sitting in a chair, and as a practicing clinician, you're trying to always do what's best for your patient, right? And so if you can have an agent and it's going to cause less pain in your patient, I don't care what chemicals that is or if it's homeopathic, as long as it's working effectively. Of course, that's the end goal. Then the fact that it's homeopathic and it's more natural and it's, not as drug-y, with chemicals that way there. That's another advantage, of course. Of course, there's nothing wrong with that. And it's, to be able to say that to your patients is, of course, it's nice. But at the end of the day, like I said, I'm just looking for things that work most effectively for patients.
Mm-hmm. Now, your line of research focuses on, cellular level and a lot of regenerative technologies. We recently did a survey of our audience, and one of the questions we asked them was, what area of development and technology that's happening in dentistry do you see as having the biggest impact in changing the industry going forward? And while we had CAD CAM and we had imaging and all sorts of high tech things, regenerative technologies and research in that area came out as the most commonly selected choice by our audience. And I guess one, is that at all surprising to you, or do you think this is something that dentists should all be excited
I think a little bit of both, to be honest with you. So I would say probably the two main areas of exciting future research is digital technology, number one, and number two, and not one is better than the other, but the two main ones is digital technology and regenerative strategies with these materials. As we learn more and more about the way that the body works and just the science behind how regeneration occurs, you start to see, this molecule, this regenerative strategy works very well for this. And you can start to pinpoint different growth factors that are doing different things. And you see a few of these commercially available recombinant, which means it's made in a lab, growth factors that are specific to different functions. Some growth factors are specific to bone, right? So that's your BMPs. And you can take these growth factors and, no kidding, you can place them anywhere in the body, for example, just in the middle of muscle, and it will make bone right in the middle of muscle, which with a liquid growth factor. You don't need a bone graft, you don't need anything, just the liquid. And the more you can find these little biomolecules that do different things, for example, other ones will induce cartilage regeneration, right? So that field there is very exciting, because then you can literally fine tune things to the point where you're saying, this growth factor, I want it to do this growth factor, I want it to do that. And that whole space of the future of regeneration is just extremely exciting. Yeah, absolutely.
Are we going to get to the point where, rather than cleaning out the decay in a tooth and then essentially plugging the hole with some foreign material, we're going to be able to inject some sort of growth factor solution and let the tooth essentially regrow itself?
There's different components to that question, obviously, and
Yeah.
some of them are realistic and some of them are just absolutely not realistic. For example, enamel, the problem there is that once the enamel's grown, there's no cells that are there,
Hmm.
right? So it's when it's gone, you can't really regenerate it, because there's no cells that are there to help with regeneration for those types of defects. And I don't work specifically in that research field, so I don't know if they can chemically somehow figure out a way to regrow enamel. I'm not the person that's an expert in that field. In perio, though, it's different, right? Or in bone, if
Yeah.
we want to regrow bone, we can do this fairly predictably. Perio a little bit less. And that's where using things like growth factors and other things really comes into will really have a very big potential for future work. Regrowing an entire tooth, like I said, I don't think I'll see that in my lifetime personally. Uh,
Hmm.
at that point, there, it's just too far out there. The problem is that there's too many of these little proteins that are doing too many different things at too many different steps, that you have to get every single one perfectly oriented in a big scaffold. And I mean, it'll be
Hmm.
years before we figure all that out.
Hmm. But in terms of for implant cases and making more and more patients viable to have implant placement, are we at a point where we can confidently provide the regeneration we might need around their bone structure?
I think so. I work a lot on the developing these types of biomaterials, right? So we develop biomaterials years before they ever get launched commercially, and then I'll be able to work with different clinicians in different fields that are using them. And I think one of the most exciting ones, like I said, and it's been around for a long time, maybe not fully utilized, is the one of BMPs, where I think with these growth factors that are really morphogens and they can really transform a tissue into bone. It's amazing what this stuff can do, like I said. And I've had the pleasure of working with guys like Dr. Picos, who uses it for a lot of his grafting cases, as well as learned a lot from Dr. Bob Marks down in Miami, who's an oral maxillofacial surgeon. And he was one of the first guys, or the first person, to really characterize osteonecrosis of the jaw. And that's
Mhm.
when you have open wounds and a lot of, or cancer lesions where they have to literally take out, for example, half a mandible, and they
Yeah.
just take it out, and he'll go to the tibia, take out a chunk of bone from your tibia, and then replace it there and try and rebuild structures. And he did that for many, many, many years. And today, he no longer needs to go to a second site and harvest, bone from another place. He says, "I'm going to do this case fully with tissue engineering." And you say, well, what is tissue engineering? And then he talks to you about all the things that he's doing, which includes, platelet concentrates, it includes allografts, it includes bone marrow cells, and it includes BMPs, growth factors. And with those combinations that he's specifically utilizing, he can predictably regrow that missing bone without having to go to your leg and,
Hmm.
take out a big chunk of bone, which is amazing. So then for your patient, it's a question of, what would you rather me do? Go to your leg and take out a chunk of bone, or, buy $5,000 worth of biomaterials and do tissue engineering, right? And most people will just say, look, here's the money. I just want to, to minimize having to go to a second site. So it's interesting, like I said, what a lot of people are working on, and we're still ways away from that. But for it to be used in everyday practice, and I think 3D printing is another one that's very exciting as well. Like I said, the ability to you're missing a certain amount of bone. You can scan your face, get all the dimensions, and then you can go to a scanner and literally 3D print bone grafts. Infiltrate that with stem cells and different types of platelet concentrates, etc. That whole space there is amazing as well.
Hmm. Do you see that the ability to 3D print essentially biological structures and substances that are going to be completely biocompatible as in the realm of possibility in the near future?
Yeah, absolutely. I mean, it's already being done. So that's not it's not a, can we do it? It's that part there, we can do, definitely. That's not like growing a tooth.
Mhm.
And the biggest limitation actually, so you can 3D print, for example, hydroxyapatite,
Yes.
and you can 3D print bone structures and other things, and you can then add stem cells or platelet concentrate. This is done routinely in research facilities and university hospitals. The problem is trying to get FDA clearance for some of
Hmm.
these technologies is very, very challenging. And I think we're still a few years away from doing that stuff there. But that is one that I think, between the digital technology and the biologics coming together, I think that will be a nice place where people will do a lot of great things in dentistry.
Hmm. So it sounds like we're taking the production technologies that are already in use. We're taking the research on the biological side and what actually is happening at the molecular level with the structures inside the oral cavity. And if we can get those two to work together, we have kind of the next solution for this industry for restorative dentistry. Uh,
Yeah,
what you're
for
saying?
yes, restorative surgical is the
Mhm.
area that I work in a lot. But
Yeah.
I mean, it's amazing what these guys are doing with digital technology today. Absolutely fascinating.
Hmm. Are there other areas of research that you're currently working on that you think are going to, have results that could be as significant as this recent study with StellaLife?
I mean, yeah, of course, we're doing many, many things that are in the biomaterial field that are, equally as impressive, no question. I would say, this is one study, but our group is publishing probably between 30 and 50 studies per year.
Hmm.
Okay, so we're just publishing almost every week something else, and it keeps us all working 7 days a week, all day, all night. But some of the ones that's really cool is tetranite is another biomaterial, and it's a bone adhesive, and so it literally glues bone to bone, and it has a strength of 300 pounds.
Wow.
Okay, so you can literally take a bone tissue and a bone tissue and glue them back together. So, example, you go skiing, you fracture your femur, you don't necessarily need to get a plate with screws and other things. You can use this new type of biomaterial and literally glue bone to bone together. And the way that this was figured out, actually, it's interesting a story, because I know some of the researchers that were involved with this from the beginning. It was a group at MIT and Harvard, and they were interested to figure out, why is it that certain underwater creatures can stick to bridges, coral reefs for hours at a time, right? Why is it that some of these creatures, for example, sandcastle worms, they can go to an underwater bridge and they stay
Hmm.
stuck there for hours and hours, and they just hang out there? How can they stay glued underwater to that bridge? And so these guys started studying again at the molecular level and cellular level, what is going on, which proteins are responsible for that. When they figured that out, they isolated that protein, and then they incorporated it into like a bone glue. So it's just a normal liquid that has this protein inside of it now. And then when you mix that with a bone graft, it literally sticks bone to bone or bone to implant contact. So the one study that we've done more recently, and this was as well done at the Picos Institute after the animal studies were done, in humans, let's say you're going to place an implant and you can't get the implant stable. So, you take out a large first molar,
Hmm.
trying to get stability of your implant, but it's a big tooth, you can't get stability. Now you could use this new bone adhesive and around the implant, and immediately it's just rock solid, perfectly stable. And what that allows is that instead of having to take out the tooth, put a bone graft in, graft the area, wait 3 months for it to heal, turn over into normal bone, then place the implant, then load the implant, etc. Now you could do that all in one step. Okay. And it was amazing to see the cases that Dr. Picos has been doing there. And that's a real cool technology, no question.
Yeah, that definitely seems like that will make things easier for both patients and clinicians as they can, speed up the process and more immediately provide functional care to patients. Well, Dr. Miron, we really do appreciate you joining us here today. It's been a very interesting discussion. I'm looking forward to following some more of your research because I think you're looking at some of these key issues that are going to be impacting dentistry, and you're finding some neat outcomes. I got to say, I was really impressed with what this study showed, and hopefully, dentists will take a look at this and maybe change how they're using chlorhexidine in these situations.
Yeah, I think, if I could just give a piece of advice for those is
Hmm.
just, try it, because you'll see for yourself, like I said, and they have done some nice studies that you can read that are clinical based. So third molar extractions, read those studies as well. But just, it's not expensive. Buying this stuff is, less than $30 for, a kit for your patient. Give it a go and just see for yourself is the best advice that I can give you, because many big clinics, well-known clinics, have literally changed over entirely. They just said after you've done it a few times, you just say, okay, that's it. I'm cutting out the chlorhexidine. I'm using this stuff here permanently. And it's one thing for me to just say it, but it's another thing for you to try it and believe in it. It's cheap. It doesn't cost very much money, so it's worth investigating. So to colleagues that are dentists, especially, give it a go and just and see for yourself.
Wonderful. Well, we once again thank you very much for joining us. Maybe in the future we can have you back to discuss some other research you're working on.
Sure, I would love to. Absolutely. Okay. Thanks for everything, Noah.
Have a great day.
You too. Bye bye.